Dear members of the chair, dear audience and guests, welcome to the 6-month progress report of my PhD thesis, the role of radioembolization in patients with liver tumors. My name is Alexandra Ádám. I am a 6th-year medical student and a first-year MD PhD student representing the Department of Interventional Radiology from Semmelweis University in Budapest. Our team consists of my supervisors and co-investigators. Throughout my future career, I would like to treat patients with liver tumors in a less invasive way by enhancing the role and impact of interventional radiology through the broader use of radioembolization in oncological therapies. To achieve these goals, I have 2 specific ongoing projects in the field of radioembolization. Regarding the first one, the applied methodology would be a systematic review and meta-analysis, while the second one, we would like to conduct the research in the form of a retrospective cohort study. Both of them were started in autumn 2024. So now I would like to talk in details about my first project, investigation of the effect of radiation lobectomy in patients with liver tumors. As you may all know, liver cancer is the 3rd most common cause of death worldwide, causing more than 800,000 deaths every year. Hepatocellular carcinoma, or HCC for short, is about 90% of primary liver malignancies. Moreover, the liver is also one of the most frequent sites of metastasis, especially in patients with history of colorectal, pancreatic, or breast cancer. The gold standard therapy for liver tumors is the surgical resection, which is considered to be curative. As any other types of surgery, it also has its own complications, namely the post-hepatectomy liver failure, being the main cause of mortality after a major liver resection. The reason of this liver failure is the small fetal liver remnant, or FLR for short. What is the fetal liver remnant? It is part of the liver that hasn't been resected, so what the patient will have after the surgery. If the fetal liver remnant is not large enough, the liver will not be able to maintain its crucial functions and the patient can die. In order to prevent our patients from this liver failure, we would like them to undergo surgery with a larger fetal liver remnant, and to achieve this sufficient increase of the FLR, we can use either radiation lobectomy or venous deprivation techniques because they can induce the compensatory hypertrophy of the contralateral lobe. So my biggest aim with conducting this research is to understand the effect of radiation lobectomy as a potential bridge to surgery treatment. And therefore, our clinical question is radiation lobectomy safe and effective to increase liver hypertrophy in patients with liver tumors? To structurize our research, we are using the PICO framework, where we are comparing different types of interventions to address the following outcomes: fetal liver remnant hypertrophy, the resection rate, and the overall survival. And if our hypothesis gets confirmed, the results of this research can be directly translated to patients' care, and radiation lobectomy can serve as a potential and substantial treatment prior to surgery. The clinical implication would be the improvement in overall survival and also in resection rate. At this slide, you can see some of my key articles which were used for the feasibility check of the topic. We are mostly expecting observational studies. We couldn't find, if I remember correctly, there were some RCTs, but mainly observational studies. And due to the low number of direct comparative studies, we are also going to pool single-arm studies. The literature research was conducted at the end of November last year with the following search key in 4 different databases. Domain 1 refers to the disease itself, and domain 2 to the different type of interventions. We got in total more than 9,000 hits, and after the duplicate removal and title abstract selection, more than 600 records remained. Currently, we are at the phase of the full text selection. About 70% of the full text selection is already done, and we would like to finish it by the end of next week. So moving on to my second project, it is about investigating the safety and efficacy of radioembolization in patients with hepatocellular carcinoma. The average survival rate of HCC varies between 6 and 20 months. The most recent guideline, which was updated in 2022, however, gives only recommendations about single lesions which are smaller than 8 centimeters. First-line therapies of hepatocellular carcinoma include resection, ablation, transplantation. With these treatments, the expected survival rates can be above 5 years. However, if these treatments fail to any reason or are not feasible, there are some other alternative treatment options, such as transarterial chemoembolization or transarterial radioembolization. So, due to the lack of guideline, there is an unmet need for the treatment of single lesions which are larger than 8 centimeters. We are also using the PICO framework for this research as well, and we hypothesize that treating single lesions, hepatocellular carcinoma larger than 8 centimeters with radioembolization is at least the same safe and effective as treated with other types of treatments, local, regional, or systemic therapies. And the clinical implication would be the improvement in tumor response rate as well as in overall survival. To summarize my 2 projects, we would like to submit the first one this year in August, and hopefully the second one also at the end of this year. As a closure of my presentation, I would like to quote the words of the American Nobel Prize-winning geneticist Barbara McClintock. If you know that you are in the right track, if you have this inner knowledge, then nobody can turn you off, no matter what they say. Thank you for your kind attention.
Thank you. Questions?
So I would like to ask that what are the main differences between radiation lobectomy and the venous deprivation?
Mm-hmm. The main difference is the access route. So in case of radiation lobectomy or radioembolization, we use arteries. I mean, we occlude the supplying arteries of the tumor with microparticles loaded with radioisotopes. And in the case of venous deprivation techniques, we occlude the veins of the liver, the portal, and the hepatic vein with different materials like coils, plugs, also glue, and that's the main difference. So the access route, arteries or veins, I would say in brief.
Thank you for your great presentation. I would like to ask, how do you measure the future liver remnant?
Yeah, there can be imaging-based volumetric assessment, so mainly high-resolution contrast intensity, also MRI. There are softwares which can calculate the exact volumetric data, so the volume of the segments, of each liver segment. And there is also functional assessment, namely the technetium mabrofenin hepatobiliary scintigraphy. It measures the liver uptake and the excretion of the radiotracer. And there is also another test called the indocyanine green clearance test. So there is a volumetric and also a functional way of approachment, I would say.
Thank you very much.